Hi there, my name is Leanna Ferguson, and I'm going to speak with you about type 1 diabetes in adolescents. My PICO question is how do adolescents ages 13 to 18 with newly diagnosed type 1 diabetes perceive their treatment during the first 6 months of diagnosis? So how did I even get to this topic of interest? Well, adolescence is already a difficult developmental age, and adding in an illness such as type 1 diabetes can really make it more challenging. And you're already at this stage of life where there are so many physiological and psychological changes occurring that you're now adding in an even more demanding management to their lives. According to the American Diabetes Association, about 208,000 Americans under the age of 20 are estimated to have diagnosed with type 1 diabetes or diabetes in general. You know, throughout my nursing experience, I really hadn't had much education or interaction with adolescents. However, the few times that I did, it truly did speak to me, as I worked in the intensive care unit and I had 2 patients that I met while working who were diagnosed and admitted with diabetes ketoacidosis, and they were both teenagers. I related to them as I was close to their age. I was able to open up with them, and they really started to trust me, and finally were able to discuss what causes them not to manage their diabetes. One of them talked about their family life, the difficulty of managing their disease, and really what seemed to be no family support. Also, she truly had little understanding of the disease and the effects that it can have on her body in future. She was not compliant because she truly just didn't care and felt as really though nothing would happen to her. My other patient, also a female, her main issue was of compliance, of not fitting in, not being normal, being accepted by her friends, her students. She didn't want to check her sugar because it looked awkward, and she actually just managed her diabetes by how she felt and would give herself insulin that way. She did have some family support, but not as much as I felt she should have as a girl who seemed lost and truly uneducated about this disease. So therefore, with all this being said, while trying to come up with my PICO question, I really wanted to do something that hit home, and I knew I would probably come across as a future family nurse practitioner, eventually dealing with this age group and this very important disease process. Of young people's perspectives of living with type 1 diabetes. But this study is actually quite interesting because the perceptions actually varied by their level of metabolic control, which we know as our hemoglobin A1C. And then they detected if these perceptions varied by these controls. It is a qualitative, descriptive study, level 6 evidence. And in this study, there was 14 participants between the ages of 11 and 22 who were diagnosed with diabetes for at least 2 years. There were 7 participants in each group, and in this study, participants were interviewed about their perceptions of living with this disease, and then major themes were identified through a process of induction. They had open-ended 60 to 90-minute audio-recorded interviews where the participants could talk freely, and they discussed their experiences living with this disease. The 2 groups were compared and then found the similar and different themes according to their hemoglobin A1C levels. So the similarities and differences were the findings that we came across, and the similarities were the perceptions of their family members, people outside of the family, the healthcare professionals, and their actual knowledge about this disease. The differences between the 2 groups came from illness perceptions, their parental involvement, and the self-care attitudes and activities. We'll talk with the similarities first, as the family perceptions identified that parents were concerned for their child, but actually sometimes too worried. One of the participants discussed how she wanted to go visit her brother who lived a farther distance, but the parents were just concerned and too worried that her diabetes would get out of control. Participants also discussed that the people outside of their family really didn't understand the disease at all. They were concerned about them pretty much just about eating sugar, and that a lot of people outside of the family didn't even know that they had the disease to begin with. Furthermore, participants actually felt that healthcare professionals were too authoritarian, and they actually felt a lack of emotional support, that they couldn't open up or even discuss their disease in general with their healthcare providers. And then lastly, the participants both seemed to understand their disease and how it would affect their future careers. Some of them talked about how they wanted to get into the healthcare field to better learn about their disease because they felt that they could really relate to people. But then some of them understood that there was careers that they couldn't even get into with their disease. One of them wanted to be a pilot, but now understands that that's not a possibility. So there were three major differences between the two groups relating to the illness perceptions, the involvement in their self-care. With illness perception, those with the higher levels actually thought that there would eventually be a cure for this diabetes. They perceived their initial diagnosis as traumatic, and they actually truly enjoyed going to the diabetes camps. Whereas the low-level groups really truly didn't think there would be a cure. They actually readily accepted their initial diagnosis, but they rarely mentioned the diabetes camps, which is interesting because you would think with the lower levels they would be more supportive in the diabetes camps, but that wasn't the case. In the theme of parental involvement, both participants said that they were primarily responsible for their care, but mostly their mothers helped them. However, participants in the higher levels had minimal parental involvement. They were actually trusted to care for themselves alone and had little consideration with their meal choices. They really didn't care what they ate. Participants with lower levels had very involved, supportive parents. Their parents encouraged them to participate in the care for themselves, and they actually had high consideration for appropriate meal choices. Lastly, there were differences in self-care attitudes and activities where those with higher levels avoided caring for their disease and did not count carbohydrates, whereas those with lower levels were highly responsible for caring for their disease and did count the carbohydrates and made a conscious effort to do so. So overall, the study shows that interventions should be focused on education and proper encouragement from healthcare, psychosocial issues, and family support, and all of this combined can lead to better outcomes and hopefully decrease the prevalence of this disease in this age group. The next article that we're going to discuss is about the experiences of adolescents that live with the diabetes, but it also is interesting because this article wanted to build a theoretical model to help with this process. So it wanted to understand the experiences, but it also built a model that helped adolescents normalize their lives while living with this disease. This is a qualitative study, but it also used classical grounded theory. It was a level 6 study. There were 11 participants that were interviewed. There was one focus group, which was performed, in which questions were geared towards the diabetes. Data was analyzed, and actually codes were connected to create this model. A major hypothesis of building this model was that in helping the adolescents normalize their lives with managing diabetes, it would actually lead to a decrease in hemoglobin A1C levels. It would decrease their hospitalization with diabetes ketoacidosis, and then increase their ability to cope with the disease. The subjects were ages 11 to 15 who had diabetes for at least 6 months. Participants were actually recruited using posters, mailing letters, and seeing handouts at clinics. And then the data collection, like I said, consisted of interviews that were actually performed with purposeful sampling, which helped provide anchor interviews and identify the initial codes needed to make this paradigm and this model. And then additional interviews were conducted using a theoretical sampling, which provided more detailed information about the growing theory and then eventually saturated the data. The interviews were digitally recorded. They lasted approximately 60 minutes, and there was one focus group that was conducted with all participants. In the focus group, the researchers found 6 major phases, and these phases were the actions in which the adolescents took to manage their diabetes. From these phases came the normalizing task that corresponded. The theory that essentially developed was about normalizing and the process of how adolescents with this disease normalize their lives while also transitioning to independence. So first, let's talk about recognizing my life is changing. This is discussing how individuals have to learn their new disease and the medical implications that go along with this. One of the participants talked about realizing that her life essentially is changing. It's not what it used to be, and now she has to take on this task and this new journey of life. Second, we talk about taking action to prevent crisis. This is how adolescents struggle with understanding what a normal target range of their glucose is and the burden that can come with checking your sugar, eating correctly, and just really staying on task and preventing low blood glucose and the side effects that can happen. So third, you have disclosing to engage support. And this involves understanding how the individual is different, how they might not feel normal, and how to integrate their disease and their normal activities outside of the home. Because inside of the home, they might feel more comfortable, but how to move this journey outside of the home. So next you have taking on the burden of care, which deals with taking over care from your parents, and possibly they discuss the parents just not wanting to let go. The conflict that might arise between the parent and the individual, and then now fully realizing how hard this might be and really taking on the care that they need to move towards their independence. Next, you have accepting the new normal, which is involving the individual realizing that they can manage their disease and truly accept that it's a part of them and that they can move forward with this. And then lastly, you have hoping for a normal future. This is wanting to actually mentor others with diabetes and being encouraged to go into the medical field, as we talked about with the first article, wanting to get into the medical field now that they're understanding this disease and all this that is involved. So to tie it all together, these interviews talked about the challenges that were faced by these individuals and then turned into a model to help them get through each challenge that were made into phases. So I think that the clinical significance to this is that the model can be used by healthcare professionals to help these individuals proceed through each phase and be utilized to be a tool that can help them accept their diagnosis. So the last study that we're going to talk about, again, talks about the challenges of living with type 1 diabetes, but this kind of focuses on children and youth perspectives. And although this is a bit younger than what the PICO question population is, it actually showed a lot of findings that were quite appropriate for decreasing the prevalence of diabetes also in adolescents as well as youth. As I mentioned, they wanted to understand the perspectives of children and youth living with this disease. And the subjects were recruited from 2 diabetes organizations in western states where purpose of sampling was conducted to find 16 children and youth with type 1 diabetes. Participants, of course, had to be deemed by their parents as capable of providing assent for the participation. You had 6 audio recorded focus groups. This is mostly focus groups that were conducted. And during these groups, participants were asked a series of questions used that helped stimulate the conversation about their experiences, their challenges, and their concerns. The recordings were transcribed, and then themes were located using inductive analysis. So the tool used in this study was the focus groups. And like I said, participants were of a younger age. They were actually between the ages of 7 and 16. So the findings from this article had 3 themes: a low blood glucose, self-care activities, and feeling different and/or alone. The first theme involved knowing when one's blood glucose was actually low, having someone actually help them in the situation, and knowing activities that can cause this and what to do when they actually happen. Most of the participants knew when they were low and how to seek help, but the challenge was actually how to deal with the low level. Also, although individuals knew they were low, some actually didn't want to stop what they were doing to interrupt their ongoing activities to actually fix the problem. They just felt it was a burden. Furthermore, The self-care activities involved checking their blood glucose and administering insulin, and these were actually a daily struggle due to the pain and inconvenience that these individuals discussed. They talked about how they would sometimes avoid the entire process completely because they just didn't want to poke themselves. And then lastly, participants felt different from their peers. They even felt alone with the challenges of testing their sugar and administering the insulin. They felt that their friends wouldn't accept them, and then others felt alone as they really didn't know someone with this disease and really couldn't relate to someone to discuss what they were going through. This challenge didn't just cause psychosocial differences, but to avoid appearing different, they wouldn't adhere to their self-care procedures, which then, of course, resulted in poorer control of their sugars. You know, for the significance of clinical practice, that healthcare providers need to be aware of the challenges that are actually faced by these individuals. And although providers may not be able to ease all of the concerns, such as administering insulin because it has to be done, they still need to address and respect the issues that come up. The study is also significant as it brings a better understanding of the perception and helps to better educate, understand, and hopefully encourage these individuals with a truly life-changing disease. As an adolescent and a youth is obviously very difficult with many challenges that are faced. And while diabetes is a well-known topic among society, the fragile age of youth and adolescence truly needs to be supported and encouraged. Each article did have similar themes as well as differences in themes, but the themes will help with the healthcare professionals to better understand how to help these individuals control their diabetes. All three studies discuss the need for parental involvement and how it can be helpful, but also it can be overwhelming. And it also talked about how we need to help them transition into the phase of the parents letting go to letting them truly take on the responsibility of this disease. And whether it be letting go or being more involved, that there needed to be some type of support for these individuals. Also, the studies discussed the challenges of self-care with the difficulty of injections, the inconvenience of checking and monitoring their blood glucose, and knowing the signs of a low blood glucose level. You know, we had the discussion of the article that talked about the normalizing process of how these individuals can integrate diabetes into their daily life. And they came up with this model that could be useful not only for those affected, but also healthcare professionals to help these individuals get from each phase. You also have the perceptions of friends and families where the articles discussed that the individuals were concerned with the friends and families' perceptions. And I was actually concerned that the perceptions of friends would be different and be actually a hindrance to their care, where really it seemed that in a lot of the articles I may not have discussed that the friends were actually very supportive. It was actually the participants that were more concerned about what their friends thought, when really their friends wanted to help them. One of the kids talked about how he didn't feel well and his friend helped walk him to the school nurse and to help him with what he was struggling with. So I was actually quite surprised and happily surprised that the perception of friends was actually positive, but how unfortunately the participants let it bother them more. And then we also found out that the understanding of diabetes is just not understood completely, and that they really needed to understand the process, they needed to understand what the effects can cause, and that there needs to be greater education for these individuals to truly get through the phases and through the processes that deal with the diabetes to get them to their future, because it's very important. So there were two methods of evaluation used in these studies. You had focus groups and you had interviews. One of the articles, the Freeborn article, used focus groups where their participants were actually asked certain questions. This was the article that had the younger population. The article talking about the high and low levels, they used interviews where they also used open-ended questions where I discussed that participants could talk freely and their questions were asked if needed. And then the normalizing article talked about the 3 interviews that they use with purpose of sampling and how they also use theoretical sampling to help the subjects and saturate their data. Focus groups are obviously what they are. They're groups. They obtain the perception of the participants in a more focused area where the setting is more permissive. It's not as threatening. They are designed to obtain of a normative group, not individual perspectives. And then interactions can probably actually help the individuals express and clarify their views in a way that's different from one-on-one interviews. Whereas interviews, these are interactions between the researcher and the participant, and this obviously produces data. It allows for a more one-on-one discussion, which could lead to a more clear communication. And actually, interviews are mostly used in descriptive qualitative research, as is focus groups, but they can be used in other areas as well. But I feel that these methods were very purposeful and very useful and obviously correct in helping gather the information and data that these articles needed. So there were many interventions and recommendations throughout all three articles. And while there were similar and differences, they all had a main focus of key elements. So first you have the education, and this is not only the education of the adolescents or the youth, but the parents as well. And it's not only on the disease itself, but what skills are needed to manage this disease, the education in the process of diabetes, if or not there's a fear of needles, and what the proper use is of all the tools used to manage this disease. Then you have the intervention of an increased interaction with others who actually have this disease, whether it be diabetes camps, support groups. One of the articles talked about how the involvement of the diabetes camps and discussed how individuals really didn't have the availability to relate to others with type 1 diabetes and how they felt so different, and how interaction with these individuals could probably help them ease their way into this disease and feel more of empowerment and encouragement to do so. Furthermore, you have family support, which is truly essential for the successful management, as involvement can improve self-management. However, there does need to be a period of letting go and letting there be a smooth transition into the independent management. And we saw in some of the articles that it was hard for parents to let go, and that there was either too much family support or not enough family support, and that there needs to be that transition to really let the individual have the responsibility and understand what that means. So this leads into other interventions in a transition period, which gives them the more responsibility. And then it helps them handle the challenges and solve the problems that may arise when dealing with their diabetes, whether it be preventing low blood sugar, handling this issue if it were to arise. And then finally, you have the healthcare support. As the support and encouragement from your healthcare teams, you need to advocate for these individuals. You need to truly address and respect their concerns. I feel that the use of the normalizing process and the model that we discussed can also be beneficial for tackling these interventions and helping these individuals truly integrate their diabetes into their daily lives. So a lot of these articles also talked about the recommendations that they would do to further their research or what they would do differently. The articles recommended using different geographical locations, as a lot of these were based in the western states. And then they also talked about different ethnicity and socioeconomic groups. This was to evaluate if this would change the outcomes and the challenges depending on these differences. And then furthermore, they talked about the need for intervention groups. So now that these interventions are identified, they want to put them into practice and now evaluate the outcomes and see if this will help and address the challenges. Lastly, the article about normalizing discussed the need for system changes and for advocating for funding for therapies and technology to help these individuals have a more normal life. What I loved about my research was that I found articles that discussed the challenges, talked about the perceptions, but then I also had an article that gave providers a tool that could be useful to help these individuals normalize their lives, as this is obviously a problem that they're having, is integrating this disease into their lives, as this is now something that they're going to have to deal with forever, essentially. And that this normalizing process touches on the main challenges discussed in all these articles, and this truly provides a tool that could possibly help in the process changes. It is obviously evident that there needs to be a practice change. And from the findings of the research, and that there's not much research out there for this topic to begin with, a lot of the articles talked about that they started this research because they realized that there wasn't a lot to even make a practice change, and that they wanted to make an effort to bring about what was actually going on with the perceptions and the challenges that these faced. As I discussed, there were many interventions that came from these studies, along with recommendations that were noted to further the research. And all of these are great starting points to start to change the practice and then further the research and the interventions that were proposed. So as I mentioned before, the normalizing process developed to help individuals integrate their diabetes in their lives, and this could truly be a great tool for the providers to start implementing in their practice and note the changes in their patients. While there still needs to be more research, I feel, the changes that could be implemented now, such as an increased education and support, will of course come with an increased cost. And these changes will eventually need more education for staff to in turn properly educate the patients. Along with the possible need to add more staff to accommodate the changes, whether it be in the office or whether you actually have an educator solely for the purpose of this age group, or even just the materials needed to change the effectiveness. I will talk further about my proposed project in the next slide. But there obviously needs to be a practice change, whether we do it now or just take what we've learned now and see where it takes us in the next step. And it mainly starts with an education plan that truly needs to be implemented for patients, for families, not only about the disease process, but what goes into this process, what to look out for, just pretty much what to expect from the tools used to the outcomes, and really get the family involved and get the support from each of them to really be able to work together. And then also help in the transition phase, as this will be later on in the education, but the transition phase of taking on more responsibility and truly understanding what comes of this. Then, of course, the diabetes camp support groups, hopefully getting resources available for these patients to get involved with these camps, to get involved with support groups, to not feel alone, to really get support from those that they can relate to. With all of this education, I hope that healthcare support and encouragement would be obvious, that we truly value you as an individual and as someone that has to deal with such a hard, life-changing disease. And then hopefully they will see that we truly do support them and want to encourage them through this process. Not only now, but for the future. I would think that this would truly be implemented in the office setting, as if I were the healthcare provider. I would want to start this in my office setting and really just focus on my patients now, whether it be an office setting in my family practice or even trying it in like an endocrinology office where this would be more useful, as well as because they deal with this disease process a little more. So not only do you need to educate the individuals affected and the families, but you also need to educate the staff. They can go to conferences about diabetes, but also not understanding diabetes, but understanding the psychosocial, the physiological, and the developmental changes that happen in this age group. And then the thing is that I know you need stakeholders, so maybe consider insurance companies taking on the money that goes into these education plans. Maybe they can even help support the diabetes camps, but if not, maybe community leaders can be stakeholders in helping these kids get to diabetes camps, get to support groups. I'm sure that it's already a lot of money to manage your diabetes, between blood sugar testing, between insulin needles, and all that goes into this, that I'm sure it will be a hard burden for these families to get to go to these support groups. So maybe getting the community leaders involved to help these individuals and make it a true community effort. The evaluation of this project could be through the metabolic control levels, if they're within the norm, to see that they're actually truly controlling this level, as well as a survey. Maybe survey the participants and the families to see how they like this education plan, how they like this program in general. And then, of course, true follow-up. We really need to follow up with these individuals, and I wouldn't want this project to be a one-time thing. As we can see in these articles and in this research, as I discussed talking about diabetes within the first 6 months of treatment, unfortunately a lot of my articles, but yet fortunately, a lot of my articles dealt with 6 months up to 2 years, and there was still a problem at the 2-year or greater mark. So there really needs to be a continual follow-up to continue to encourage these patients, because they're going to go through a lot of developmental changes that could change their attitudes towards this disease process. And then you have the outcomes. I want to have increased adherence to management. I want to have more support and encouragement, and hopefully get positive attitudes towards this disease, not only from the patients, but from the families and from the siblings, and all that goes into truly helping these patients manage this disease. As we have already discussed, it is a life-changing process. So in conclusion, we can obviously see that diabetes is still prevalent in our society with, as we discussed, an estimated 208,000 affected by this disease. Youth and adolescents are faced with so many challenges and struggles when dealing with type 1 diabetes, as we've seen through the research presented to you. This population should not go unnoticed, as they are our future, and they deserve the same respect. They should not be brushed off as non-compliant or unwilling to learn, or pushed aside and misunderstood. These studies may not primarily address adolescents, as we also discussed youth and children, but evidence shows that the challenges and perceptions are similar, and practice change is truly needed. Furthermore, these findings were of individuals diagnosed with diabetes outside of like I said, the PICO question of 6 months. However, this has shown me that there's obviously still a challenge later on in life, and it is evident that there must be some type of lapse from the initial diagnosis until years later. So often the question of "how are you" is skipped by the statement of "tell me what's wrong with you today." And these studies have discussed that this age group is struggling with what is asked of them to treat this disease. And we as healthcare providers need to be proactive to make a change and truly impact the lives of their future. Whether we are more creative and interactive with education, we encourage support groups or camps, implement tools, or simply listen to the concerns of these individuals, we can make a change for them. I will definitely be trying to utilize these findings in my future practice. I hope that I have brought light to you about the perceptions and the challenges of these adolescents dealing with type 1 diabetes, and hopefully encourage you to use this data and this evidence to make a practice change as well. Thank you so much for listening, and I hope you have a wonderful evening.